Over the last 28 days, amongst the infected cases, the percentage of the unvaccinated who became severely ill or died was 5.2%, while that of fully vaccinated was 0.8%. And this means that if you are still not fully vaccinated against the COVID-19 virus, you will have more than 6 times, in fact, it's 6.5 times a higher likelihood of getting a severe infection and a bad outcome compared to a fully vaccinated person. The number of new cases reported daily has risen very quickly over the last 2 weeks. Yesterday, the Ministry of Health announced a total of 450 new local cases of COVID-19 infection in Singapore. This is in contrast to 216 new local cases reported 1 week earlier on the 3rd of September and 120 new local cases the week earlier on the 27th of August. This doubling of new local cases weekly reflects an ongoing community spread of COVID-19 that has taken place as we lightened the community restrictions after our phase 2 heightened alert phase, and has allowed more social interactions then to take place. In our epidemiological investigations, we have identified transmission occurring in workplace, social, and household settings, contributing to the large clusters that we had to then deal with in the Bugis shopping mall, at bus interchanges, and at other work sites. These transmissions may have been facilitated by the increase in mask-off, close physical interactions occurring between individuals and amongst groups of people. There were also breaches in safe management measures and poor compliance in mask-wearing requirements in some of these cases that possibly further contributed to spread. The phylogenetic tests that were successfully performed on the cases to date have shown the Delta variant to be currently the dominant COVID-19 virus-causing infections in our community. Compared to the wild type or other variants that we encountered last year, the Delta variant has caused a different clinical and epidemiological pattern to the COVID-19 infections that we encountered now. And this is driving the present rapid rise in infections. So what do we know about the Delta virus variant as it applies to us? First, the Delta virus is highly infectious and transmissible compared to other virus variants that we have encountered in the last 20 months. We've seen a number of super spreading events arise this year related just to the Delta variant, with multiple generations of spread across different geographic settings. This includes the Jurong Fisheries Port cluster, with further spread taking place through fishmongers and other stall holders and operators who shuttle back and forth between the port and wet markets across the island. Beyond these fish stall operators, further spread had taken place to other stall operators and the market, and even cleaners, patrons to the affected stalls, and then subsequently to household members. Our National Center for Infectious Diseases, or NCID, has demonstrated that infected people with the Delta variant may have high viral loads at an early phase of their infection, and this is particularly for unvaccinated but infected cases, and they have more prolonged shedding of the virus compared to other variants. And this does contribute to the overall increased transmissibility seen with this variant. Patients who are symptomatic from COVID-19 infection have had their symptoms manifest over a variety of different durations of incubation period, from the time of exposure to the time in which they manifest their symptoms. And this can take up to 14 days. However, compared to last year, with the wild-type variants that we encountered then, we've seen more people presenting this year with shorter incubation periods, with a mean of 4 days or less, compared to a mean of 6 to 8 days previously. And this means it takes a shorter time for people to develop the infection and to be infectious, even before they become symptomatic. The shorter incubation period leads to a greater risk of amplification and dispersion of infection if infected people continue with their social and work activities, particularly if it's working away from home. It is therefore not surprising to see large clusters of cases then detected at the onset when we pick up an initial case of COVID-19 in the community. The larger dispersion makes it more challenging to manage and control clusters. And with a rising number of cases and clusters in the community, it becomes even more important for us to adjust our contact tracing, testing, and isolation strategies to try and limit further spread. Firstly, more frequent testing is needed, with tests that have a short turnaround time for results to be acted upon quickly. And this should be done at the workplace and within households as soon as infected cases are detected. We have distributed nationally ART test kits to facilitate more widespread testing, and individuals who are detected to have positive ART test results should seek medical attention, self-isolate as soon as possible, so that we can perform confirmatory PCR tests for COVID-19 and then follow up accordingly. Workplaces are encouraged to implement regular routine testing, and a high testing culture will help us to detect cases as early as possible before too much spread has occurred in that workplace. The Delta variant also causes more severe infection. In many countries, including the UK and in Israel, Delta infections have been shown to be more than twice associated with the risk of hospital admissions compared to infections by other variants. Our local study conducted by NCID has confirmed that patients with Delta infection have a higher risk requirement of oxygen support, ICU admission, and even death. The overall case fatality rate per 100,000 cases in the first 8 months of this year with Delta infections was 27.61. And this was nearly 7 times higher than the corresponding case fatality rate observed in the entire duration of last year, 2020. Vaccination against COVID-19 still makes a difference. NCID has shown in a study of households exposed to an infected household member in the Bukit Merah outbreak that vaccinated individuals have nearly a 2 times reduction in their risk of getting infected compared to unvaccinated people, despite being exposed to the same infected person. The risk of needing oxygen support and of needing ICU stay is also much lower if you are fully vaccinated. And while about 0.1% of vaccinated but infected persons need ICU care, the proportion of unvaccinated but infected persons needing similar ICU care is about 10 times higher. And there's also close to a 16 times lower probability of death if you are vaccinated. So for those of you who are vaccinated and say you're aged between 60 to 69 years, your risk profile has changed with vaccination. Your need for oxygen supplementation or ICU care is now lowered to be similar to that for unvaccinated people less than 50 years of age. Studies in other countries like the UK have shown similar findings of a protective benefit with vaccination for seniors. Our increase in community cases has not been associated with a corresponding increase in the numbers of people needing both oxygen support or ICU care. And notwithstanding the doubling of cases that we are now seeing every 7 days or so, the number of cases in the ICU remains relatively low. And the cases have been predominantly frail seniors with chronic medical conditions and unvaccinated people. This is an encouraging trend, even though we do not wish to see any person coming into the ICU for critical care. And we need to monitor the situation closely for the next 2 to 3 weeks to see if this trend between seeing high numbers, yet with low numbers of people requiring ICU care, continues. And to see if our local experience matches that seen earlier in the UK, where a big rise in their total number of infections following the removal of community restrictions in what they call a Freedom Day, they didn't see any correspondingly large spike in the number of ICU cases or the number of deaths. And we hope that our local experience will be similar